Hello everybody, this is Andrew Hill. I'm a surgeon at Middlemore Hospital and an academic at the University of Auckland, and Nick Lightfoot, who's an anaesthetist at Middlemore Hospital and a co-conspirator in a number of research projects.
Hello.
Hi Nick. We're talking about complexities of emergency laparotomy, and which was the topic of the NIAS meeting that was held in Sydney a couple of months ago, and we were asked if we could have a bit of a chat about that and talk about some of the issues that arose out of the meeting. So Nick, we've got a few things we're going to talk about.
Yeah, sure.
I think the first thing we thought might be useful was to talk about risk scoring. Now, one of the key components of the NELA, National Emergency Laparotomy Audit from the UK, or from England and Wales, was the use of risk scores, and they used POSSUM, but I understand there's now a NELA score as well. But did you have any comments on the use of risk scores in emergency laparotomy, or what you thought about them, what we could do differently, what's missing, those sorts of things?
Yeah, so I guess the National Emergency Laparotomy Audit is one of their benchmarks, mandates the use of a risk score in the preoperative and in the postoperative period of patients who are undergoing emergency laparotomies. And as you alluded to, I guess, risk scores are basically trying to model a population. They're taking some of the population's, preoperative parameters and trying to predict how the patient is going to do postoperatively. And I guess, there's no perfect system which is able to 100% of the time say that this patient's going to have, a mortality and this patient's going to have a bad sort of morbid outcome. So basically, they're trying to predict the future using the best possible data that they have in the preoperative period. As you said, the P-POSSUM model, which followed on from the POSSUM model, did have some problems. It was prone to overestimating the mortality of patients, particularly the very high risk patients. Someone who might have a 50-50 chance perhaps with surgery would predict that that patient may have almost a universally fatal outcome. And the people from NELA have collected large amounts of data. We're talking 30,000 patients per year in England and Wales who are enrolled in NELA. They've collected several years of data to formulate a new score, and they reckon that this new score may potentially have some benefits perhaps over the POSSUM-based system. We could talk a little bit more about that later on if you liked.
Well, there's a few things that I've got a bit of an issue with about POSSUM. So you're absolutely, what you say is absolutely correct, and probably not any great news to anybody out there in that P-POSSUM, even though an improvement over the original POSSUM score isn't enormously accurate and does tend to overscore. And New Zealand's always been particularly proud of that because we felt that we were sort of ahead of the game, but in reality it overscores even in the environments in which it was started off in the UK.
Yeah.
But one of the problems is the POSSUM score does require intraoperative data, and so you're guessing beforehand, aren't you?
Yeah, correct. So I guess the POSSUM score has two main components. It has a physiological score, and you're able to look at into the components of the patient's physiology that you have in front of you before the operation. But you do need to estimate things. Does the patient have cancer? Is there soiling of the peritoneal cavity? How much blood loss the surgeon's going to have during the particular...
Now, in my case, that's always easy, but some other surgeons, there's plainly going to be a lot.
Yeah. There's a multiplier. I'm not entirely sure what it is for all of the different surgeons. That's right. So you do have to estimate, and whether this is a major procedure or what they describe as a major plus procedure, so a minor or moderate or a major surgical procedure. So I guess there is an element of estimating with the surgical, the operative morbidity score associated with the POSSUM score, yes.
One of the things that... And the other thing, which we'll talk about a bit later, I think, is their inability to predict disposition of the patient. So, because that's often a much bigger deal to patients than whether they're going to get a wound infection, or it may be that they don't care too much if their mortality is 10% or 9%, but they do care where they'll end up.
So I guess with something like mortality, it is quite a hard sort of endpoint. You're either dead or you're not dead, right? And patients are usually, to a degree, able to understand this, what it means. But when it comes to predicting other complications, things like, renal failure, pneumonia, wound infections, having a heart attack after surgery, these are just numbers to some patients. They don't actually know what these events mean. And as you allude to, whether it means that if the patient develops pneumonia or that wound infection after surgery, it may mean that they're no longer able to be independent at home and they perhaps have to transition to maybe private hospital level or rest home level of care, which may be something in their own personal sort of, life schema, which they don't particularly want to do. So that's important information.
And for some people, that's worse than death, isn't it?
Yeah, correct. And I guess like in what we'll talk about in the future, the current Australian and New Zealand laparotomy audit, one of the things that they're looking to do is both predict risk preoperatively, and then also have discussions with the patient about the goals of care. You know, what they want, what the patient wants to happen, should there be a cardiac arrest, where they want to end up after surgery, those sorts of things. So that is quite important.
Another thing we've been thinking about, you and I and in my research team, is that let me try to get this concept across. You know, bringing what we know from elective surgery, where we can do, say, you know, CPAT testing, and then use that to help predict outcomes. It seems to me that these patients have had a cardiac pulmonary type of test by the sepsis that they've got now. And so if one of the things we've done with what's called the SPI score, SPI score, which we published a few years ago, we looked at changes in patients' physiology that had occurred. So we often know what the diabetes was like, or the blood pressure was like, say, a few months ago, or the kidney function was like.
Yeah.
And then we see what it is, you know, now with this test of a physiological insult.
Yeah.
And we were able to quite accurately predict outcomes based on that change. All these scoring systems so far have used only a point in time measure, as opposed to looking at how it compares to other people. So, for instance, a blood pressure of 100 may be actually quite normal in some of our little old ladies, whereas in some robust younger guy, it may in fact be very, very low.
Yeah, I guess what you allude to is entirely correct, and I guess there are burdening fields of research, you know, at least amongst anaesthesia, as to the impact of hypotension in the perioperative period. If you actually look at what the definition of hypertension is, it's incredibly difficult. Someone, I think back in 2007, published in Anesthesiology, what is the definition of hypotension? They looked at 100 different papers and they managed to find 120 different definitions for hypotension.
Right.
I may be making those numbers up, but it was certainly a large number of definitions for hypotension. So it's difficult to define hypotension if we actually don't know what the definition is, if that makes any sense.
And look, wooden sorts of numbers where we just use a number,
Correct.
It seems to me to not be very helpful. You know, in the perforated duodenal ulcer literature, a lot of which came out of Hong Kong a long time ago, blood pressure of 100 systolic was looked at as hypotension.
Yeah.
You know, and you know, proved to be quite a useful measure, but actually at the end of the day, there have got to be better ways of doing it.
I think so, and I guess, you know, we probably will talk about this again later in terms of goal-directed fluid therapy, measuring sort of advanced hemodynamic parameters. We need to find a way that we can sort of associate these advanced parameters and use them to our advantage in predicting patients' outcomes, and we'll probably talk a little bit more about that shortly, I would have thought.
So in Australia and New Zealand now, we're looking at doing something similar to NELA. We're not fully off the ground yet, and this has been called ANZELA.
Yes.
Where's that at the moment?
I believe if you look at the literature on the College of Surgeons website, the initial meetings to plan the development of ANZELA took place in perhaps June of last year, and I believe it was launched at the combined College of Surgeons, College of Anaesthetists meeting in Sydney, which was that in May or April this year?
It was in May.
In May this year. So I believe it was launched then. If you look at their website, in New Zealand, I think we have at least one hospital, which is Auckland City Hospital, which is enrolling data, and potentially another 6 or 7 hospitals, which are looking to start enrolling data. And then over in Australia, there are a large number of hospitals which are also entering data into the ANZELA system. So I guess the pilot phase of the project is at least underway. So I had a look at their information, I think yesterday, compared to NELA, ANZELA does have a few core differences. It's more looking at patients with acute abdomens as opposed to purely emergency laparotomy for bowel surgery, and also looking at patients who have an acute abdomen and then don't go on to have surgery. So the true denominator of patients who are undergoing emergency laparotomy can finally, or who come in with an acute abdomen requiring an emergency laparotomy can finally be defined, because there is, as you're probably aware, a group of patients who present to hospital who maybe have non-operative management, or patients who are deemed too unwell for surgery, who go in to pass away from their illness without having a surgical procedure, and those patients by themselves are very interesting. They're also looking at a broader range of patients compared to NELA, not just bowel surgery, but looking at patients perhaps with diverticulitis or something like that, or post-operative patients who've had another operation before this need for emergency laparotomy. And they're also looking at futility of surgery, including a frailty score and documentation of the goals of care, as I said before. And there are some key differences between the United Kingdom, where the vast majority of patients present to hospital, have their surgical procedure, and then have post-operative care, whereas in Australia, apparently patients are transferred between hospitals willy-nilly, talking large numbers of patients, perhaps I can't remember what the number was, but it was a considerable number of patients present to one hospital, then are transferred to another hospital to have their emergency laparotomy, which can have, I guess, some implications on the benchmarks which are recorded through the audit system.
So one of the problems with the NELA system has been the collection of data, because it's quite intensive, and it does probably require people other than the clinical staff to do it.
Yeah.
I think this has been one of the things that's been holding up NZELA from really getting off the ground.
Yeah, certainly
This
particularly at our Middlemore Hospital, it is. Some hospitals do have better IT setups and are able to electronically collect a large amount of this data. But as you do say, there are multiple points of data collection, multiple phases of data collection: the preoperative phase, the intraoperative phase, the immediate postoperative phase, then a 30-day follow-up. So it does require, considerable periods of, amounts of work to get that full data set which is required. And if you look at patients who have bits of information missing, the evidence from NELA is that there may be, perhaps slightly different to the patients that do have the full data set. For instance, the patients who have don't have a preoperative risk score predicted, those patients actually have a higher perioperative morbidity, or mortality should I say, than patients who do have the preoperative mortality risk predicted. So it's important to get all of the data for these patients.
Yeah, it's interesting, because that preoperative risk score guides a whole bunch of things.
Correct.
That perhaps we wouldn't have thought about so much before. I think one that may or may not be relevant in New Zealand is the presence of a consultant anaesthetist and a consultant surgeon for anybody with a risk greater than, I think, 5%, is it?
Yeah, it's 5%. So seen by the surgeon before surgery or within 14 hours of admission to hospital. And then if the predicted mortality from the P-POSSUM score, at least initially, that may have transitioned to the NELA score now, needs a consultant surgeon and a consultant anaesthetist in theatre. And looking at the UK data, at the moment, the specialist surgeon and anaesthetist in theatre, they're sitting at around 80%. The surgeon in theatre is about 90%, and the anaesthetist in theatre is about 85%.
I'm quite surprised that it's as low as 80% actually, because certainly our own experience here is it'd be pretty unusual situation where a laparotomy occurred, at least an emergency one occurred without a consultant surgeon and anaesthetist, at least for some of the time in theatre.
Yeah.
They have to be there the whole time to count.
I actually don't know. I guess probably the most important time would be the huddle at the start of the operation before people lay hand on the patient. That may actually be the point of data recording. But you're correct. Like, I guess, a routine laparotomy, in a lower risk patient, perhaps not, the extremely high risk patient, and maybe something that is done.
Yeah, I think the thing that may be something that would change would be the kind of the insistence that people with high risk end up going to ICU, even if they don't look like they're high risk at the time, because that's not the way we've done things. We've tended to look at them in recovery or during theatre, haven't we?
Like, I guess, there is the realization that the perioperative period probably does extend, for quite a considerable period of time beyond the time that the patient's in the operating room and the recovery ward. And it may be that you've got that honeymoon period after the operation when the patient does look really good, and then it's at that 12 to 24 hours after surgery when the decline can really
Especially if it's
occur.
on a Saturday and they're going into Sunday and no one's around.
Yeah, and it's house officer changeover time. Yeah, that's
Yeah.
right. That's right. And I guess looking at our data, which we briefly did, several years ago, I think, I do have this written down here somewhere, around 40% of our patients after emergency laparotomy in 2015 went to the intensive care unit after
So what do you think
surgery.
the numbers would rise to if we followed NELA guidelines strictly?
I think, they're looking at 80% of patients.
Yeah, 80% plus.
With the more than 5% sort of mortality predicted. Yeah.
Which in a small hospital is not such a big deal, but in a
No.
bigger hospital where you're getting several of these patients each week, it can be potentially a bit of a burden.
It
can't
definitely has implications. And if you look at, any patient's, HD or intensive care admission, it's generally not for a 12-hour period of time. These patients are often in the intensive care unit for 2 to 3 days, and that may be because they're unwell, needing fluid therapy, needing vasoconstrictor therapy, but they may also get bed blocked because it's winter,
Yeah.
because there's patients on the ward who have coughs and colds and they can't get out of the intensive care unit. So it does definitely have implications, and it's something that we as clinicians and the health system will probably need to think of in the future if we are looking to follow these guidelines which are prescribed by NELA.
Now, there's an interesting thing that's sort of implied by all of this, and that is historically surgeons were always in a hurry to get people with an emergency laparotomy to the operating room.
Yeah.
And anaesthetists were kind of like saying, well, yeah, how about you resuscitate? Now there's almost a shift here
Yeah.
in which the surgeon's saying, I want to get this patient as crisp as possible. And the anaesthetist saying, NELA guidelines say if you're actually at high risk, we want to get you within a couple of hours. It's an interesting shift in frame.
Yeah, I guess it is. And I guess probably like many things in life, people will flip-flop between the two extremes. It seems that we've, swapped roles, at least initially. And there will probably be some sort of, happy medium between the two extremes. For some patients, categorically they do need to go to theatre straight away. Maybe, someone with an exsanguinating, GI hemorrhage that does require, emergent surgery to stop the bleeding. That patient probably needs to go to theatre straight away for simultaneous surgical therapy and resuscitation. Whereas other patients, potentially there is more time for a bit of preoperative resuscitation, which can be guided by various, different markers and that sort of thing. Yeah.
So, Nick, as you're aware, a few years ago we did some work, admittedly in elective surgery, looking at goal-directed fluid therapy using the esophageal Doppler.
Yes.
And we really didn't find it particularly useful in elective surgery in an ERAS context.
Yes.
Is the emergency laparotomy patient a different kind of situation? I mean,
Yeah.
obviously, they've got different kinds of fluid issues, but do you think that we're going to be using goal-directed fluid therapy? If so, what? And what sort of goals are we looking at?
So I guess you've made a couple of good points there. I think the elective patient in fluid therapy is not the same as an emergency laparotomy patient, right? You've got patients who may have fluid deficits from blood loss. They may have an acute inflammatory state. They may have vomiting, diarrhea, third spacing, whatever that means, of fluids, meaning they may have quite a considerable fluid deficit. Whereas that elective patient often comes in, they're relatively euvolemic. So you're basically just, keeping up with fluid therapy and replacing any losses. So these are two different sorts of patient sets. So I guess the optimized study, which is probably, I can't put my hand on my heart, the largest study of goal-directed fluid therapy was published in JAMA in 2014. And associated with this study, and I think as a criteria to get published in JAMA, they put out a meta-analysis. That showed that goal-directed fluid therapy, as you said, is not associated with any short or long-term benefits in mortality after largely elective surgery. So the people who came up with the optimized study, they've had a look at these emergency laparotomy patients. They've stated that a patient, who's 50 years of age, has approximately 20-day, 90-day mortality after their emergency laparotomy. And if there is a patient group where the goal-directed fluid therapy is going to work, it's potentially the emergency laparotomy patient. So in the United Kingdom, there's a study called FLOW-ELA, FLOELA, I guess you'd call it, which is enrolling patients looking at the use of cardiac output monitors. That's either esophageal Doppler or pulse contour analysis, and I guess looking at a monitor that will produce an estimate of the stroke volume variability, and using that guide to help treat or help guide fluid therapy in patients undergoing emergency laparotomy. So to show a difference, a reduction in mortality at 90 days in these patients after surgery from 19% to 16% is going to require a sample size of around 8,000 patients. They started enrolling in 2017. They've got 500 patients at the moment. So in a couple of years' time, we may see some information about goal-directed fluid therapy in emergency laparotomy patients.
Are they using two different kinds? They're using both the flow track or something like it and the esophageal Doppler?
I had a look at the protocol yesterday and I can't actually remember if they specified. I believe that Optimize, the original study I talked about with their meta-analysis, used esophageal Doppler. And esophageal Doppler does have some good evidence surrounding it, perhaps some of the best evidence. But if you use it, and I'm sure you have, it can be a little bit finicky getting it to sit well in the esophagus, getting good recordings. Whereas pulse contour analysis, you've got a patient who has an arterial liner, and there are sort of variants of the flow track system as you described now, which basically use a fingertip sensor monitor. I forget what that's called. It used to be called the CC Nexfin, which can produce the same sort of estimates from just basically saturation probes.
I've been really quite cynical about that approach myself. And the other, and I'm sure you give lots of evidence for it, but I've just
largely against it.
Yeah, exactly. So I've been rather quite cynical.
Yeah.
But it seemed to me that these goal-directed fluid therapy approaches, that the idea is to sort of get to the top of the Starling curve, and I'm just not sure that's the best place to be, or is it? Have I got that wrong?
I guess.
I mean, my point is, when you're at the top of the Starling curve and you get it wrong and you go the wrong way, then you sort of move from being at your peak to being to being worse.
I think you're probably right. I think it's probably, and maybe a slightly not what you're saying, but I think...
No, I'm being oversimplified, I agree. But
I think...
I'm a surgeon, remember.
The use of these monitors and these goal-directed packages of care may be slightly oversimplistic, trying to load the patient, as you say, to that, the flat part of the Starling curve, and hopefully associated with the flat part is not a precipitous decline on the other side. But I guess if you look at the response, or, a patient's response to the amount of fluid that they receive, and perhaps some complications, things like renal failure, maybe mortality, rather than these being like exponential curves with, on the far right-hand side receiving lots of fluid and having lots of complications, and on the left-hand side really receiving hardly any fluid and not too many complications, these response curves may actually be U-shaped. So for every particular patient, there is this sweet spot of fluid administration, which is going to stop them getting pneumonia, stop their kidneys from stopping working, stop them getting wound infections, making sure the heart pumps well after surgery, and of course for you guys having a nice, well-perfused gastrointestinal anastomosis.
We just care about the anastomosis.
That's not swollen. Yeah, exactly. I guess unfortunately for every patient, probably that sweet spot is slightly different. So it's very difficult to tease out, how much fluid a particular patient needs. And if you look at the evidence for, goal-directed fluid therapy, the amount of fluid that these patients receive, is basically the same as patients who don't get goal-directed fluid therapy, if not more. So I guess it's just the way that you give fluid, whether you give, high basal infusions of like sort of crystalloid fluids, or whether you give low infusions plus intermittent boluses. The actual end number is the same.
Part of the problem, though, is you can't actually determine where it goes, can you?
No.
We don't have good ways to do that.
No. I guess we have...
So you can put a lot of fluid in, but it may not get to my anastomosis.
Correct. We have ways that we can do it. You can measure, pHs and perfusion, using ultrasound or implantable probes, hypothetically almost anywhere. The problem with that, and you've seen that information, I think, a few years ago we were speaking about gastric tonometry and perfusion of the GI tract. You can measure this pH through a fancy nasogastric tube, but the number actually doesn't mean anything. So that's what I was alluding to earlier, should I say. We don't really have, some sort of good, endpoints that help us guide our resuscitation. Even something like lactate. When lactate is positive and you've got a patient's got a really high, preoperative lactate, if someone's got a lactate of more than 4 and a systolic blood pressure of, less than 70 millimeters of mercury, if you put all of those patients together, there's a 60% chance of mortality. That's in patients with sepsis, right? But, you might have a patient who's almost exactly the same as that patient who has that systolic blood pressure of less than 70 and the lactate of 4, but their lactate's not 4. For whatever reason, their lactate hasn't gone up. That patient may still have exactly the same outcome. So lactate, is positive and its negative predictive value. It's not entirely perfect.
But you don't want to lactate that high, though, if you can avoid it.
Oh, definitely not. No. It's slightly more complicated than that, but yeah.
But for a surgeon, that'll do for today.
Yeah. In terms of, lactate production, then lactate clearance and all that sort of
So
stuff.
look, one of the things that confuses me with emergency laparotomies is that we put a patient up for one and you guys come down, have a look, or we send the patient up to theatre, and then there's this kind of higgledy-piggledy, jiggly-piggledy, hokery-pokery, and then we're allowed into the operating room to do something, and the patient may have an epidural, may not, may have an arterial line, may not, may have a central line, may not.
Yeah.
What's going on there? Is it different? Is it just heterogeneity of anaesthetists, or is there some sort of way you're thinking about all of this? Or how should we think?
I think if you were to break it down, it's heterogeneity of anaesthetists. So taking it a step further back to fluid therapy, what we were talking about in the United States, people have looked at this in a large, I think it was group practice or something like that. They corrected basically for surgical duration, surgical complexity and patient comorbidity, and found that the amount of fluids that different anaesthetists provided to patients was basically one of those curves that, how would you describe that? Like a
S-shaped curve?
An S-shaped curve turned on its side. So there are extreme outliers and then a group of people, who sit in the middle. So some people give hardly any fluid, and that can be extremely hardly any fluid for any particular operation. Could be a lap chole, could be an emergent right hemicolectomy, and some people give a huge amount of fluid, whereas, it largely collects around, perhaps the mean. Or the median. The same is true for the use of invasive monitoring devices. There was a paper published, I think, in the journal Perioperative Medicine a few years ago, which looked at basically surveyed anaesthetists in Europe and in the United States, and the amount of monitoring that these different anaesthetists in these two different continents would use to care for the same same mock patient is completely different. In the United States, they still have a penchant for the Swan-Ganz catheter, whereas in Europe, it's more derived parameters from arterial lines and central lines and that sort of thing. In Australia and New Zealand, I guess, for patients who are really unwell, having an emergency laparotomy, I'd like to think that myself and most of my colleagues would use an arterial line. The use of a central line, I guess you need to consider why you're going to be using that central line. There are better ways to give intravenous fluids to patients. So if a patient needs a large volume transfusion or resuscitation, that could almost be done better through a wide bore peripheral line. Whereas if a patient needs vasoactive medications, things like noradrenaline or adrenaline infusions, then a central line is required. I guess, maybe we could talk a little bit more about analgesia after patients having an emergency laparotomy, and whether a patient gets an epidural or a patient doesn't get an epidural is, I guess, a difficult question.
So what sort of things go through your mind when you're thinking about that decision?
I guess in this day and age, and working at this hospital, you need to consider, what the epidural is going to add. In the elective patient population, epidurals provide great pain relief, if not the gold standard of pain relief. But they're not, they are associated with complications. Sometimes they fail, sometimes they make the patient hypotensive, sometimes it leads to the patients getting more fluid. Can make patients feel itchy, can put them into urinary
In somebody
retention.
who's already got vasodilatation from sepsis, can an epidural make that worse, or is it already vasodilated as much as it can be?
I guess probably the short answer is maybe. Yeah, I think those are patients that we would be probably a little bit reticent for putting an epidural in for two main reasons. If you have sepsis, you're putting basically a needle into a privileged space of the body, like the epidural space. If you were to hypothetically introduce infection to the epidural space, the complications could be quite dire. We're talking an epidural abscess, which can lead to neurological deficits, paraplegia, the bowel bladder never working again. So those are really sort of bad complications. So we don't want that to occur. And then also there's the hemodynamic sequelae of inserting an epidural. The hypotension, the further vasodilation that it can occur with inserting an epidural. I guess the vasodilation that occurs with sepsis, sometimes I guess that may be, not the same in all organ particular systems. So I suppose an epidural, yes, in that scenario could exacerbate the hypotension. Yeah. So I guess those thoughts go through your mind. Probably these days, for me, the main thought when I'm considering inserting an epidural is, I know I can insert an epidural. I know I can look after that epidural during the intraoperative period. I know I'll probably still be around, at 6 p.m. when the patient's in the recovery ward. But what's going to happen, for the first 12, 24, 36, 48 hours after surgery when the patient's on the ward? How is that patient going to get cared for? So that's a really important sort of thought that goes through my mind, ensuring that we have a pain service that can follow the patient up, whether we've got access to a high dependency ward so that patient can be cared for properly, so ensure that they don't get massive amounts of fluid or they're left hypotensive on the ward. I think that's probably the worst thing that can possibly occur. Yeah.
So while our surgeons are busy thinking about what the heck's going on in there, we also are and should be thinking about issues about surgical management of these patients. And I wanted to just talk briefly about some things we talked about a little bit before, and those things that people regard worse than death. So nobody likes the idea of being on dialysis, even whether they understand it or not. Very few people like the idea of a stoma. And one of the problems with a stoma is we know that a large proportion of these patients, maybe up to half of them, never get the stoma closed, even if we give them a temporary one. Large proportions of patients, given that many of these patients are older, the idea that they'll move from being independent to being dependent, whatever that might mean, is a huge issue for them. And these are issues we need to think about as going to theatre. So, for instance, certainly, this idea of damage control type surgery is one that we need to think about. And so this idea that you get in, control sepsis, and then get out of there is sort of one end of the spectrum. The other is this kind of idea that we as surgeons will try to do the definitive operation here and there, no matter whether the anaesthetist out there and is trying to pump fluid in, trying to giving a variety of different things to keep the blood pressure up and so on, and we'll just box on for 3 hours, 4 hours, maybe even doing it laparoscopically. And I think as surgeons we need to kind of think very carefully about these people. So it starts in the kind of discussing things before surgery. So usually we have a rough idea what we might find. Often it's not exact. We often don't know exactly, but we often know pretty much. And especially with the Neela and Anzela approach to early CT reporting, consultant CT reporting, we have a better idea than we're used to. And then we need to couple that with talking with the family and their relatives about what are the things for them that are worse than death.
I think so,
And we haven't done that very well as surgeons. And the kind of the pointy end of this comes to when we're in the operating room and we have a choice as to whether to do an anastomosis or to give the patient a stoma. Now, let's just imagine, we know that in most of these kind of environments that doing an anastomosis has a higher risk of anastomotic leak than in the elective environment. But we also need to bear in mind that the chance, if we give the patient a stoma, and it's a temporary type of stoma, then there's a high chance to get rid of it, obviously going to require another operation, which will usually be quite a major one. And if we also know that only about half of the people will end up representing for that, and of course it has its own risks and so on. So, sometimes we have this idea in surgery of kicking for touch and just we'll bring out a stoma. Sometimes we just need to say, well, look, there's a risk if we do an anastomosis that this person will leak, but it's not as high as the fact they'll have a permanent stoma, if that makes sense. These are the kind of things we need to think about. The other thing is, I read a paper recently, was our practice with perforated duodenal ulcers in New Zealand and in many parts of the Western world has been to put a patch on them and then treat them with H. pylori afterwards. In H. pylori treatment afterwards. Interestingly, quite a few of these perforated ulcers are not H. pylori, not caused by H. pylori, and there's apparently, although not my experience, but a moderately high risk of these recurring. So do we have to go and do an old-fashioned operation in the context of sepsis, the anaesthetist wrestling with the patient? And so these are some of the kind of issues we need to be thinking about as surgeons, rather than where we need to be working more with the patient beforehand,
Yeah.
incorporating risk strategies, incorporating discussions with the patient on what's worse than death for them, and what we find in the operating theatre.
Yeah, I guess, there is a movement these days for towards, I guess, what they call advanced care planning. Basically, people thinking about, what they want to occur, and, it's particularly in patients who are at the start of probably an illness which may end up taking their life. I guess, and sometimes we do have that information to hand in a patient who presents for an emergency laparotomy, but sometimes we don't. But, talking to patients about, what would be a particularly bad outcome is particularly prudent for these patients. So it can help perhaps, sculpt, their particular care. So I do agree with you, yes.
Yeah, I think we've got to be a lot clever about these patients. And
Yeah.
And the challenge for all this, of course, is that this is going to involve consultants being in the hospital more. And, frankly, these things aren't taken into consideration very often. It's already hard enough being a consultant, taking acutes and so on. Middlemore has, on average, about 30 admissions a day, acutely in general surgery at least. And it's a huge burden on people. But fortunately, this is what we need to be thinking about. I wanted to ask you about this measure that's recently been reported and used a lot, and that's days alive and out of hospital. I just wonder what you thought of that measure and whether this is something we should be thinking more about.
I think, particularly in the anesthesia field of, research, randomized controlled trials, and even retrospective outcome studies, there's been a move towards, rather than looking at system-centric measures, so things like length of stay, how much it costs to look after this patient, we want to look at things that have a patient-centric measure. So, basically, the crudest way of doing that is going up to the patient with a microphone and saying, "How are you feeling?" But it can be very difficult, to do that, particularly if you're looking at the data retrospectively, because you don't know how the patient felt, at 30 days after surgery. So, if you had some, pre-planning, you'd be able to collect some, patient-centric recovery measures, scores after surgery. But if you don't have that, this days alive and out of hospital measure basically looks at, you've got a patient, they come in, they have their right hemicolectomy. And how long does a patient stay in hospital for after a right hemicolectomy on average, emergency in New Zealand?
A week and a half.
Yeah. So I think Neela reported 16 days. We probably must be better than them, right? So
Of course, yeah.
It'd be like 10 to 14 days or something like that.
It'll be similar to what they say, I suspect, actually.
I suspect you're probably right,
Yeah.
actually. That's right. So let's say hypothetically it's 14 days. And if you've got, there's 30 days in this hypothetical month, at 14 days you go home and then you're able to be independent at home. So you're alive and you're out of hospital. That's 16 days. That you're alive and out of hospital. But if after your 14 days you're transferred to inpatient rehab and you're in inpatient rehab for I guess, for 16 days afterwards, that you're alive, number one, which is, important to some people, I suppose, but you're not out of hospital. So your days alive out of hospital on that second hypothetical patient might be 0. And that's taken as a crude surrogate for, how a patient is doing. Are they sort of at least, ballpark back to their, previous baseline level of functioning? Because if you're at home, at least in Australia and New Zealand, well, probably in New Zealand, the assumption is that you can't have, too much, home support, additional cares to help look after you, right? Like, in other countries, perhaps you can basically have the hospital at home. You can go home, on day 2 after your anterior resection and, basically have high-level nursing care at home. Perhaps in some countries that doesn't really occur in New Zealand. So that's the, sort of the advantage of this model, that you're looking at patients, are they sort of almost back to their baseline level of functioning? So I think it does have some merit in that, particularly in New Zealand at least, there's the national minimum data set, which, every patient who gets admitted to hospital, there's, I think it's like 200 things or something like that have to be reported to the Ministry of Health. And, transfers between hospital to, public hospital and private hospital, that sort of thing is recorded in that measure. So this sort of information can be obtained through a backdoor, reasonably simply. Yeah. So I think that is the advantage of this method.
No, look, I can see that. I guess there's two things I'd say is that when you're doing studies or randomized controlled trials of this, then there's so much heterogeneity in that number that you're going to, and the numbers, the difference between 90 and 75, if you're looking at over, say, 4 or 5 months, is probably going to be statistically more difficult to detect than, looking at straight mortality figures. If you're going to go there, I would argue, if we're really going to be patient-centric, that we should look at quality of life measures, because at the end of the day, that's really what matters to people.
I guess that's sort of what I mean by like a patient-centric outcome measure. There's various, different examples. There's the quality of recovery, the QOR, the QOR 15. I think there's one called PQRS, maybe T.
We have a nice simple one called the surgical recovery score, which we've used for quite a long time.
Exactly. And I think, all of these scales, have the advantage that at least in the, the short-term period after surgery, they have the ability to detect, small differences in patient outcomes, which, sort of, correlates with differences in, how the patients are feeling. I know at least the orthopedic surgeons, and probably you guys, do have scores which are more validated for more in the long term. So I guess if you are looking at patients at that, maybe the 2 months or 3 months out of surgery, I guess there probably is, maybe it's a difficult period because the scores may be validated for the immediate period after surgery, and you may have another score which is validated for 3 to 6 months after surgery. So maybe those patients.
Well, as you know, the mortality rate for people goes out months after these operations.
Definitely. It can extend for 60, 90 days for some, some sort of morbid operations. And if you've got a patient which is, extremely unwell preoperatively, that point of inflection on the Kaplan-Meier curve, the survival curve, I've heard, people say maybe like 2 years after surgery. So it's, it is quite important to, consider.
So I think we've probably covered all the things we wanted to cover, Nick.
I think so.
I think just sort of summarising things, we talked first of all about risk scores and what's out there and what really needs to be done. And we talked about the fact the risk scores probably overestimate things a little bit. The NELA score, we just haven't seen enough of it to see how good it is.
Yeah, I had a little look at the old NELA score yesterday, and I think it is probably steps in the right direction. Number one, it's up-to-date information. Which is good. So it's it's the most recent information, whereas PPOS, and we're talking, was 1998 or
a long time ago.
Yeah. I guess it has the advantage that if you actually look at it, rather than having one score, you've got 4 scores. You've got ASA 1 and 2 patients have their own score, ASA 3 patients have their own score, ASA 4 patients have their own score, and ASA 5 patients have their own score. And there's different weights on that, acute physiology.
Which takes into some stuff what they were like previously and what.
Then I guess it considers what they were like in the past.
Yeah.
And then to that you add basically
what they're like today.
An operative and a physiological score. So I guess it's, would you call that a Bayesian approach to, risk prediction?
Probably.
Yeah. Sounds good, doesn't it?
It does. It sounds like we know what we're talking about.
Yeah.
The second thing we talked about was Anzela, and that it's sort of, starting to get underway, and that's exciting. And one thing I didn't mention there actually was that unlike the UK work, which was really, it's still being run by the anaesthetist, which is, nothing wrong with that. But the Anzela is very much a surgeon and anaesthetist run thing. Both.
Yeah, I guess I wrote down the word. It's multi-partisan.
Yeah.
Yeah. Does that sound right?
It was. Yeah. No, it's good. It's good.
I definitely agree. It's got, our 2 main colleges plus the surgical and the anaesthesia societies between the 2 countries. So I think it's really good. And then hopefully after this trial period, they'll be able to get someone to bite and then pick it up and fund it for a longer period of time.
Well, it's certainly been funded in the UK by government, hasn't it? And saved a lot of money.
Yeah, they're saying that NELA, which is 30,000 patients per year in the United Kingdom, costs £400,000 to fund each year, I think. And in their most recent report, which was the 3rd report, they're saying £30 million per year have been saved by the United Kingdom. So I guess I'm not smart.
That's why they're leaving. That's why they're leaving Europe, isn't it?
Yeah. I can't do the maths on that, but I think they might be saving some money. Yeah.
So then we went on to talking about fluid analgesia, and Anzela and NELA have been not particularly prescriptive about that, but have talked about, I think, not using a huge amount of fluid, getting the antibiotics in early, resuscitating people, but still there remains heterogeneity of care in that area and some more work to do. We then talked about whether patients should be rushed to the operating room or not, and I think what we've got is a nice little turnaround from the surgeon trying to push and the anaesthetist trying to push back to where we're probably working much more to the same kind of endpoints and same sort of aim, really. Getting the person to the operating room.
I think so. I think so. Yeah. Like you'd like to think that we're, particularly in this day and age where we talk to each other more, that we can work out which patients need to go to theatre now, the exsanguinating patients potentially, versus which patients, we do have a little bit more time, and then potentially which patients, maybe we've got a longer period of time, those sort of urgent acute patients. Yeah.
Then we talked a bit about things that are worse than death for patients and how that might influence how surgeons operate and how we do things in the operating room.
Yeah.
And then we talked a little bit about the kind of endpoints that we should be looking at, both in studies but also in our own practice. And while we may get all excited about people having left hospital alive, if they haven't left hospital happy and alive, if you know what I mean, then we may not have done them a great service.
Yeah, I think I'll agree. I agree with you on that one. And and I think this is the day and age when, system-centric measures may have, had their time in the sun, and we need to consider patient-centric outcomes, rather than just measures that mean something to,
There's a nice little story on the NELA website in the third report that you described by a patient, actually.
Yes.
And she's the lead story, and she talks about how, and I think we forget this, actually, that she was sitting at the beach having ice creams or something one day, and the next day she was in hospital with a perforated, whatever it was. I don't think she said what she had, actually, but she was saying she didn't know how complicated it was, and in terms of the system, the people need to be brought to bear, and the way it all works, and I think one of the things we as surgeons and anaesthetists forget is how complicated it is. We've got used to it.
I think originally we were going to talk about who owns emergency laparotomy, but we sort of stepped back from that. So hypothetically, you've got this patient, they come into hospital, they're seen by an emergency department nurse, admitted under an emergency physician, get seen by the surgical registrar, get seen by the consultant surgeon, then they come to theatre where they meet a whole lot of people, the anaesthetist, the surgeon, the nurses in the operating theatre, the anaesthetic technician. They might go to the critical care unit, then get looked after again by the surgical doctor, and then finally go to the rehabilitation ward. There are heaps of people who are looking after these patients, and I think we've all got our own little piece of the pie, if you want to consider it that way, and it's important to talk together rather than siloizing the care. I think that's probably a really important thing, which maybe neither is helping us to do.
Well, that's exactly what I think, and that's where I was going to finish this off, if all right with you, and that is I think the audit stuff, when you're trying to change complex systems, if you try to look at one spot, it just messes it all up.
I think so,
The audit system it's got a series of, I think, 9 things, right, that you're supposed to do?
Yeah, there's like 9 benchmarks or whatever.
Yeah.
Yes.
And each one of those have different things that we each contribute to. And getting that feedback to the whole system, allowing each one of us to think it through, and then looking at the principles that NELA's put in place and how we might get there, I think is a great approach, rather than having the rather siloed approaches we've had in the past.
I think so. Yeah, I wholeheartedly agree. Yeah.
All right, thanks, Nick. It's been good to talk with you again. We hardly ever talk nowadays.
No.
Different operating rooms, but
That's right.
Thanks very much.
Yeah, pleasure as always, Andrew.